Welcome everyone to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
All right, welcome bitches to the Transformation Nurse Academy podcast. My name is Kevin. Sorry I missed you last week, but I was in Vegas. Like I told you before, I work with Central Valley Medical at morethancpr.com. And we were in Vegas putting in one of our RQI heart code machines. So we'd appreciate it if you support us. I told you last week I fucked up. Sorry. I fucked up last week because I was supposed to do respiratory, but I did GI instead and shit. So this week we're going to do respiratory. Again, you can go onto our website at transformationnurseacademy.com. You can download the respiratory assessment guide. It's free now. So don't forget to try that. Sorry, my voice is still fucked up. All right, so a little brief introduction here. Again, my name is Kevin. I'm an emergency nurse. I live here in California. I've been a nurse and been in the medical field since 1987. I started my first IV in 1987. But this week, like I said, we're going to do the respiratory. The respiratory system is very important. It's important to your nursing assessment. We're going to talk about different topics inside your guide here. Let me see. Let me open my guide one more time so I can tell you here. It's 95 damn pages long. It covers respiratory assessment and patient safety. It covers an overview of the respiratory system, anatomy and physiology of the respiratory system, assessment techniques. Talks about other common respiratory conditions. It talks about respiratory issues and trauma, advanced respiratory care, some special considerations like pediatric, geriatric, cultural considerations. And then I created 5 case studies that you can practice on. And then I give you some evidence-based practices in the respiratory care for like asthma and COPD management. And then in there's a couple of resources that you can use as well. And then because somebody asked me about an ABG, I don't know if I'm going to release it yet or not, but I think I might. But if you go to morethancpr.com/ABG analysis. I have to make sure that's the right one. I just created this. Yeah. So it's called morethancpr.com, morethancpr.com/ABG-analysis. The ABG interpretation tool that I created. I had a couple of respiratory therapists I sent it to check it out, a couple of doctors. Of course, nobody fucking wants to check it out and give me feedback. So any of you want to check it out, I don't know if it's 100%, so that's why I'm hesitant to put it out, but I'll put it out anyway so you can check it out to see. What I did was I created it where you could put in the pH, the PaCO2, the bicarb, and the O2. And then I gave you the normal range and stuff. And then when you click interpret the ABG, it gives you the guide on whether it's metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. And then whether it's compensated or not. So that's a tool that you can use to try to help you with your ABGs as well. All right, so that's a good tool that you can use. So first, we're going to talk about anatomy and physiology. You know, we're going to discuss the structures. We're going to talk about the respiratory structures, upper airway versus lower airway versus lung tissue. So if you talk about your upper airway, if you know who Madonna is and you're voguing and shit, when you vogue, that's your upper airway. So, you know, when you talk about your upper airway, it's important that you distinguish between the different airway systems because you can't just mix them together. If you mix them together, so the upper airway consists of your nose, your nasal cavity, your external nose, the nasal pharyngeal structures. You have the cilia, you got the globulate cells, you got different passageways with the bones that make up the different surfaces of your bones, your nasal septum. your conchae or your turbinates, the bony projections within the nasal cavity that create turbulence in the airflow. Then you have your pharynx, which is part of your nasal pharynx. Your nasal pharynx, the upper part of your pharynx, located behind the nasal cavity. It serves as a passageway for air and contains the pharyngeal structures like your tonsils, your adenoids, which helps with your immune system. You have your oral pharynx. Your oral pharynx is in the middle section of the pharynx, located behind the oral cavity. It also serves as a pathway for food and air. Then you have your laryngeal pharynx. Your larynx is the lower section of the pharynx, extending down from the oral pharynx to the top of the esophagus. It directs food and fluids into the esophagus, and it also directs air into the lungs and stuff. And then your larynx, you have your epiglottis. You know, your epiglottis is a leaf-shaped flap that covers the laryngeal inlet when you're swallowing, preventing aspiration of food and liquids into your lower respiratory tract. And then you have your vocal cords. The vocal cords are located within the larynx and are responsible for the sound production. Apparently, my fucking larynx is fucked up today, or my vocal cords. And then you have your thyroid cartilage. It's the largest cartilage in the larynx, commonly known as the Adam's apple, and it provides structural support and protects the vocal cords. And then you have your lower airway tract, which is your trachea, your bronchi, your bronchioles, and your alveoli. All right. And then you have your lungs. You got your right lung, your left lung, and then you got your pleura. And so those are your different kinds of structures for your airway. The reason why it's important to know this because in these the way the different airways are helps with the different sounds that you'll be listening to. So if you have somebody with the upper airway and their upper airway is starting to close off, you'll have these high pitched sounds, which we call stridor or stridorous sounds. Sometimes we label them as a barky cough or a croupy cough. And then if you have lower airway obstructions due to asthma or bronchiolitis, your lower airways, your bronchi, your bronchioles, when they become inflamed and start to become constricted, you hear these more coarse-like sounds. And so in the book, though, I put on when it talks about wheezes and crackles and rhonchi, I did put links in there that you can click on the links and it will take you to the different sounds so you can hear the different sounds when it talks about rails, crackles, wheezes like that. So that way you can distinguish between the different sounds. But when it comes to the lower airway, you know, your trachea, it's a rigid, it's a I can't even talk today. It's a long, rigid, tubular-like structure that's about 10 to 12 centimeters long. So it's kind of C-shaped, cartilage-like that helps prevent it from collapsing. The lining of the trachea is like epithelial cells. It's very moist, almost like the inside of your lip and stuff. Your bronchi and bronchioles, you know, they bifurcate. So you got your bronchus, then you got your left bronchi, your right bronchi, which goes down into your bronchioles. And at the end of the bronchioles are your alveoli, which are microscopic air-like sacs clustered at the end of the bronchioles. Each lung contains about 300 million alveoli, providing vast surface area, almost 70 to 100 square meters for gas exchange. So you got type 1 alveoli cells. These are flat cells, squamous epithelial cells. They make up a majority of the alveoli surface. Then you have type 2 alveoli cells. These are more cubical or cuboidal cells, almost cube-like, that produce and secrete surfactant. And it's a substance that helps reduce the surface tension and helps prevent them from collapsing during inhalation. And then you got your right lung, which is the larger, consists of 3 lobes, the superior, middle, and inferior. Then the left lung, which has 2 lobes, just the superior and the inferior. So the reason why we want to talk about assessment, though, is because when you're listening and assessing the respiratory status of a patient, you want to make sure that your patient has good air exchange. You want to make sure that they have good gas exchange. So it's very important that you understand the different sounds, where these sounds are coming from, what areas, what lobes, what is it coming from, upper or lower. So that way you can kind of help deduce what the patient is in the emergency room for or whatever floor you work on. So when you talk about assessment, though, you want to make sure that you're paying attention to your patient, right? So what is their breathing? So we talk about assessing. You want to look at the rate of breathing. Is it normal? Is their chest rise symmetrical? Is it unequal? Is it rapid? Is it shallow? Is it deep? These are things that you want to pay attention to when you're talking about your assessment. Remember that your breathing is controlled in your is an automatic process, controlled in your central nervous system, particularly in the brainstem. The medulla oblongata contains the primary respiratory centers. One is called the dorsal respiratory group. The other is called the ventral respiratory group. Then you have your pons, and then you have the breathing center, the pneumotaxic center. You have chemoreceptors inside your brain, that help in your central nervous system, and then you have mechanical receptors as well. So when you're talking about the respiratory anatomy and physiology system, you got to make sure that you understand that these are needed for continuous oxygen delivery, carbon dioxide removal. And a lot of nurses, though, we get taught in school about O2 sets, but we don't get taught about CO2 exchange and the importance of the carbon dioxide O2 exchange. When it comes to a patient, though, you want to look at their history. What is their chief complaint? Start by asking the patient to describe their main reason for seeking care. Is it shortness of breath? Is it a cough? Is it chest pain? Is it wheezing? Do they have a history of medical problems? Delve deep inside their history. Do you have a history of COPD? Do you have a history of asthma? Do you have lung cancer? These are chronic conditions that could affect their breathing and your respiratory assessment. Does the patient have a family history of breathing issues? Do they have sleep apnea? Again, do they have cystic fibrosis? Any kind of deficiencies that could affect their breathing? Look at their social history. Do they smoke? Do they do drugs? Do they live in a house full of cats, dogs that they may be allergic to? Are they allergic to trees, mold? Those are things that you want to ask and review. You also want to review the systems, conduct a systematic review of symptoms related to the respiratory system, meaning upper airway versus lower airway versus lung, and look at the complications that go along with these different reviews of the systems that you're paying attention to. Are they on medication? So you want to review the patient's current medications, including over-the-counter medications, supplements, medications that could impact respiratory functions, such as beta blockers. A lot of times patients are on beta blockers, they got a dry cough. ACE inhibitors can cause a dry cough. Diuretics can cause fluid imbalances and breathing issues. And then when you inspect, look at the general appearance of the patient. As the patient's posturing, are they humping over? Do they got pursed lips? Do they show signs of distress versus signs of failure? Are they having severe respiratory distress? Are they tripoding? Are they leaning forward? Are they leaning back? Look at their position. Look at their skin color. Is their skin color cyanotic and bluish? Are they hypoxic? Are they pale? Are they anemic looking? Do they have any clubbing in the fingers and the toes? Look at their breathing patterns. The normal adult should be breathing 12 to 20 breaths a minute. Assess for any irregularities like tachypnea, chain stoking, things like that. Look at their accessory muscles. Are they using their intercostal muscles? Are they using their abdominal muscles? Are they using their muscles here in their neck to try to breathe in? Are they tracheal tugging? You got to look at those things like that. Look at their chest wall configuration. Is their chest wall rise and fall symmetric? Do they look barrel chested? Do their chest look concaved, or sunken? You got to look at that. Symmetry is important. The diameter of the chest is important. Any kind of deformities. Are they breathing slow? Are they breathing fast? Those are things that you want to look at. Palpate their chest. Do they have any tenderness? Do they have any masses? Do they have any crepitus, subcutaneous emphysema? And then look at their trachea. Is their trachea midline, normal position? Is there any deviation to the left and right? Right? Look at their chest when it expands. Does it expand fully? Is it symmetric when it's full? Feel, like I said, for the crepitus. Percuss. Listen to the sounds, the resonance of the resonance, the normal sound produced over a healthy lung is a hollow sound indicative of air-filled spaces. Hyperresonance, which is a louder, lower pitch sound, lower than normal, often heard in conditions with increased air, such as emphysema and pneumothorax. A dullness sound, a softer thud-like sound heard over the dense tissue, such as areas of consolidation like pneumonia or pleural effusions or tumors. Those are things you might want to look for. And then you want to listen for auscultation, listen for the lung sounds, normal breath sounds, vesicular sounds versus bronchial sounds. Vesicular sounds, low pitch sounds heard over the most of the lung fields, inspiration more so than expiration. Bronchial sounds are louder, higher pitch sounds heard over the trachea and the main bronchus. That's more on expiration than it is on inspiration. Abnormal sounds or adventitious sounds could be something like wheezes, crackles, ronchi. And again, in the ebook, I put in there the links that you click on to take you to these different sounds. And then look at your tools that you can use. Pulse oximeter, what's their normal O2 sets? Typically, the range is 95 to 100%. Anything less than 90, maybe you should start being concerned and starting to look into what's causing it, right? Anything that can affect it could be like nail polish, cold clammy skin, different kind of ambient light can affect your O2 sat. Do you have a good pleth? Is there a good waveform? You can do ABGs, look at the ABG, the pH of an ABG, the normal 7.35 to 7.45. The PaO2, the normal is 80 to 100. The PaCO2 is 35 to 45. Bicarbonate is 22 to 26. And O2 sat is greater than 95% where your ABG. So when it comes to clinical application of the ABG, respiratory acidosis is typically characterized by a low pH and a higher PaCO2, often seen in conditions like COPD, respiratory failure, and drug overdose. Respiratory alkalosis is characterized by a high pH, low PaCO2, commonly caused by hyperventilation due to anxiety, pain, or hypoxia. And in metabolic acidosis, characterized by a low pH, low bicarb, which may be a result from conditions like DKA, renal failure, or sepsis. And in metabolic alkalosis, high pH, high bicarb, often due to vomiting, diuretic use, or excessive bicarbonate intake. So those are things that you want to pay attention to. And then look at your capnography, your end-tidal CO2. Like I said, normal is 35 to 45 is your normal. Does the patient need a chest x-ray? Look at chest x-rays. These are things that you might want to pay attention to and look at the different structures when you look at the chest x-ray. Look at the different types of respiratory conditions. Are they suffering from COPD? Are they suffering from emphysema, asthma? Maybe they got some kind of pleural effusion. Those are kind of things that you might want to look at. Do they have a history of TB? Is it active TB? Is it latent TB? Is it a history of TB? You might want to look at their pulmonary. Do they have a history of pulmonary emboli? Do they have any kind of problems with pneumothoraxes? People with Marfan syndrome, sometimes they would just have a simple pneumothorax. When they come in, they're kind of tall, lanky, things like that. So those are things you might want to look at. You want to look at somebody that might have acute respiratory distress or ARD syndrome. You want to look at see if they have medications that they use. Do they use bronchodilators? Like I said, are they using short-acting beta agonists? Are they looking at anticholinergics? Are they looking at things like theophylline? You want to know the dosages. You want to know the routes, the mechanism of actions. Those things are important. I put some of those here in the book. Corticosteroids. There's inhaled corticosteroids. There's systemic corticosteroids. There's different types there I put in for you. Do they need antibiotics? Are they septic? And then I put in the different kinds that you could use. There's microlids. There's beta-lactams. There's fluoroquinolones. Then do you need mucomist expectorants? So there's mucomist. There's decongestants like antihistamines like Benadryl. So things like that you might want to look at. What kind of oxygen therapy do they need? Do they need a nasal cannula, simple mask, non-rebreather, Venturi mask, high flow nasal cannula, or do they need mechanical ventilation? So if you're using a nasal cannula, the flow rate's usually 1 to 6 liters per minute. It can produce anywhere from 24 to 44% oxygen percentage. Simple face mask, 5 to 10 liters, it could produce anywhere from 40 to 60%. A non-rebreather, you need a flow rate of 10 to 15 liters a minute, and it can produce up to 95%. Even though we call it 100% non-rebreather, it's only about 95%. Venturi mask, typically 4 to 12 liters. It can be adjustable. The FiO2 settings can be adjustable anywhere from 24 to 50%. High flow nasal cannula, the flow rate is up to 60 liters a minute, and it can be adjusted to provide 100% oxygen if need be. And then if they need, do they need mechanical ventilation? All right. So it's important to understand the different types of flow devices and their flow rates per minute, and what do the flow rates per minute produce as far as percentages of oxygen given to the patient. If somebody is having respiratory distress, what can you do to help them relax besides oxygen and these beta antagonist kind of medications? You give them sedation. Ask the doctor for sedation like benzodiazepine, propofol, things like that to help them relax. Give them analgesics like morphine or fentanyl, right? You want to pay attention to help kind of reduce the stress, because if you're stressing the patient out, their heart rate's up, their blood pressure up, their respiratory rates up, they're burning up their oxygen reserves, their glucose reserves. So you want to make sure you pay attention to that. And then if you have a patient with some kind of respiratory trauma related incident, like a rib fracture, a flailed chest, those can complicate things when it comes to your respiratory assessment. You want to look at maybe like a tension pneumothorax, hemothorax. These are all different kind of injuries that your patient can have that may cause more problems. And then if they do need mechanical ventilation, do you understand the different types of modes that the respiratory therapist is putting your patient on? Even though that you may not be a respiratory therapist, you're still responsible for the patient, and you should know about these different modes and what kind of the medical problems that the patient may have and what mode might be best for them. Does that make sense? So you have assisted control mode, you have the pressure support ventilation mode, you have the pressure control ventilation mode, you have volume control ventilation mode. Then there's ventilator settings such as tidal volume, respiratory rate, the FiO2, the PEEP, inspiratory time, the ratio. And then you have BiPAP versus CPAP. These are non-invasive ventilation devices that you can use. So these are different things that you should familiarize yourself with. So that way, if you're caring for a patient with respiratory problems, you don't just rely on a respiratory therapist, because you are on the front line and you may be seeing something sooner than they will. And then you can pick up on it and save your patient. Does a patient have a tracheostomy? Do you need to provide tracheostomy care? Right? Are you ventilating through the tracheostomy? Are you ambu bagging? Are you using a ventilator with the patient on a tracheostomy? How do you care for a tracheostomy? Do you have to inflate the balloon with air? Do you have to inflate the balloon with water? There's a cuffed versus uncuffed. Do you know what the difference is between the inner cannula and the outer cannula? What do we do for the stomach care? How do we treat that? So those are things you might want to pay attention to. If your patient does have some kind of trauma issue, do they have a chest tube in? So if they have a pneumothorax or hemothorax or pleural effusion, they may need a chest tube. How do you set up a chest tube? What does it mean when a patient has constant bubbling in the chest tube drainage system? What does it mean when they have gentle fluctuation with inspiration and expiration? These are all things that you should pay attention to when it comes to your respiratory assessment. And then look at the different types of special categories. It's pediatric patient versus a geriatric patient. So like pediatric patients, the pediatric is a smaller airway. It's more prone to obstruction than adult airway. The infant's trachea is soft, more pliable. They don't have good neck muscles, so their head bobs around. Right? Newborns, their respiratory rate is 40 to 60. Infants is 30 to 40. Children are 20 to 30. Now, I know these aren't like perfect, but they're pretty close. I did put more specific respiratory rates inside the book. What is their lung capacity for pediatrics? So pediatric patients have a less compliant lung, meaning that they have to use their diaphragm to breathe a lot. So you have to pay attention if it's a pediatric. Children have higher oxygen consumptions per kilogram of the body compared to adults. So they have a higher demand for for the need for oxygen. Number one cause of bradycardia in a pediatric patient is hypoxia. So you got to pay attention to that. And then look at their lung sounds. We talked about the same wheezes, stridor, crackles. And then things that kids get, pediatric patients, they get bronchiolitis, they get croup, they get asthma, pneumonia. So those are some things that you want to pay attention to. And if you have a geriatric patients have a decreased lung compliance as well. Their aging results in reduced elasticity of the lung tissue, leading to the decreased lung compliance. This affects the ability of the lungs to expand fully during inhalation, leading to a reduction in vital capacity and an increase in residual volume. Weakened respiratory muscles as we get older. The diaphragm and intercostal muscles weaken with age, reducing the force of respiratory muscle contraction. This contributes to a decreased cough reflex and an increase in respiratory infections due to ineffective clearance of those secretions. And then they have decreased ciliary function. The cilia is in the respiratory tract. They play a crucial role in clearing mucus, debris, becoming less effective as we get old. This results in an increased susceptibility for respiratory infections. RSV is a big one now that old people are getting and having trouble with. And that used to not be a big thing. So increased risk of comorbidities for geriatrics, heart failure, diabetes, COPD. These also exacerbate your respiratory problems when it comes to geriatric patients. So some things geriatric patients you want to pay attention for, again, COPD, pneumonia, heart failure, pulmonary fibrosis. All right. How about cultural considerations? Cultural beliefs about health and illness. Different cultures have varying beliefs about the cause of illness and the appropriate treatment. So sometimes that can be a problem. Language barriers can be a problem. So those are things that you want to pay attention to when it comes to patients with your respiratory assessment. So I gave you some case studies. One case study I have is a patient. She's 35-year-old female with a history of asthma, presents to the emergency department with worsening, shortness of breath, wheezing, chest tightness over the past 24 hours. She reports using her albuterol inhaler with little relief and feels that her symptoms are more severe than usual. Her heart rate is 110. Her respiratory rate is 28. Blood pressure is 135/85. Her O2 sats are 92% on room air, and her temperature is 99. The patient was diagnosed with asthma at age 10. Her asthma has been generally well controlled with the use of inhaled corticosteroids and short-acting beta agonists. She has a history of 2 previous hospitalizations for asthma exacerbations, the most recent one being 2 years ago. She denies any recent respiratory infections, but mentions exposure to a friend's cat over the weekend, which typically triggers her symptoms. So again, what would you do with this patient? How would you encourage her? And if she's already has wheezing and tightness of the chest, is her short-term acting beta agonist, is it really going to work? So those are things that you would have to think about when you're taking care of this patient and assessing her and reviewing her. All right. All right, so there's some case studies again. I know it's a lot. It's hard to talk about respiratory in detail, especially when it's covered so much. But this is a extensive guide that you can download and use. Again, there's the ABG analysis tool that you can use, the respiratory guide you can use. Again, you want to pay attention to your depth, rate, the sounds, the conditions of your patient. And so that way you can have a better assessment of your respiratory therapy or your respiratory anatomy and physiology for your patient. All right, you guys, sorry again about my voice. I hope that you learned a lot with this respiratory assessment guide and the tools that I provided. If you need anything, you have any questions, don't be afraid to ask me. All right, you guys, I appreciate you. You take care.
Don't miss out. Engage with us weekly. Share your thoughts, and let's transform the nursing landscape together.